I've got some objectives here. Of course, we're talking about pulmonary arterial hypertension, so we're going to start with what is pulmonary arterial hypertension. What is the current treatment? And how are we doing with that current treatment? And also, what are the recent advances in the treatment of pulmonary arterial hypertension? So, I thought I'd start first of all though with the normal lung. And it took me quite a long while actually to realise that the blood pressure in the lung is not the same as the rest of the body. I'm not quite sure when it dawned on me, but it was relatively late. And everyone else aware of that? And then I was you think about why that is the case. Why is the blood pressure in the lung less than it is in the rest of the body? Well, the blood vessels in the lung are very thin and distensible, and they need to be that way because if you think about it, when you're at rest, you have about 5 litres a minute of blood going around your lungs. But then if you start running around, you can double it, triple it, even quadruple it. But we also know that the blood vessels have to be thin, especially the little capillaries at the end, because they're important for transferring oxygen. And here we have a diagram of how the tree divides down. There are about 17 branches, and we get right down to the bottom here. And at the end of one of these is a capillary surrounding the alveolus, and that's where all the blood exchange goes on. And actually, this is an electron micrograph here. These are the red blood cells here. This is the alveolus over here, and this is the thin wall where the gas transfer goes on. It's only 0.3 micrometers in thickness. And if you had high blood pressure, if you had the same blood pressure you had in the rest of the body, and especially if you exercise, that would just blow apart. So mammals, humans, birds, they've evolved to split their pulmonary circulation away from their systemic circulation. Does that make sense? So pulmonary hypertension is raised blood pressure in the lung, and it's defined as a mean pressure of greater than 25 millimeters of mercury. We actually place a little wire into the heart and the blood vessels in the lung of the patients, and we measure the pressure. And there are essentially 5 types of pulmonary hypertension. I'm only going to talk to you about the first type, that's pulmonary arterial hypertension. And what happens in pulmonary arterial hypertension is that those thin blood vessels I talked about become thicker and narrower. And it occurs, these are the changes you see, so thickening of the wall of the blood vessel, leaving only a very narrow lumen for blood to flow through. And it occurs in blood vessels that right at the periphery of the lungs, so less than 0.5 millimeter in diameter, so the tiny blood vessels in the periphery. And the heart is a pump. The right ventricle is a pump that's used to pumping at low pressure, and it doesn't cope very well with this increased afterload because of this increased resistance to blood flow. This really is a slide to demonstrate there are several subtypes of pulmonary arterial hypertension. The top ones are the more common ones. I say more common, this is a very rare condition. So we've got congenital heart disease where the patient might have been born with a hole in the heart, so there's too much blood flowing through the wrong way into the lungs. There's connective tissue disease associated pulmonary arterial hypertension. I'll call it PAH because it's easier to say. That means like a rheumatological condition, like you may have heard of scleroderma, for instance. That's one of the most common causes of pulmonary arterial hypertension. And then idiopathic. Idiopathic means that we don't really know the cause of it, so it's there at the end when we've ruled out all the other causes. And you can see that the prevalence of all these conditions are around 10 to 20 cases per million. So it's not very common. And at the bottom, there are some even rarer causes: liver disease, HIV infection, and exposure to drugs and toxins. And the overall prevalence of this condition is about 50 cases per million in the UK. Now, we don't understand why it happens. Martin's going to tell us why it happens in his talk. But I would say that we don't fully understand why we get to that point in the middle where we've got these thickened and narrowed blood vessels. But all these factors here are probably important. We do know that genetics are important, and there is a sort of commonly abnormal gene called the bone morphogenetic protein receptor 2. Big, long name. We know a bit about it, but we know also that even if you have that abnormality, it's not sufficient to get pulmonary arterial hypertension. So you might have a family history, you might carry that gene, but you don't necessarily develop the condition. You probably need what we call another hit. And the other hit, for instance, might be I don't know, an infection, a pneumonia, or exposure to high altitude and low oxygen levels. And then that triggers off a process that then causes the development of these narrow blood vessels. This is from the national audit. All the patients in our service and all the other specialised services put all their data into a national audit, and we can get a lot of information about these patients. Now this graph here is got numbers on the vertical axis and age groups along the horizontal axis, and the light blue is females and the sort of greeny blue is males, and you can see straight away that it's more common to have pulmonary arterial hypertension if you're a woman. We're not quite sure why that occurs, but it's probably related to hormone levels. Now, if I was giving this talk about 20 years ago, I would probably be looking just in this range here with a peak in the middle. It was characteristically a disease of younger women. But now we can see that's been extended right up to patients who are being diagnosed in their 80s and 90s. Now, we're not quite sure whether this group are exactly the same as this group here. There's some reasons to think that they're probably not. But what is important is these patients will have other conditions as well, like lung disease and heart disease, and that will make treatment of these patients a little bit more difficult and how they respond to treatment. So what does a patient with pulmonary arterial hypertension look like? So here's one, Tess. She allowed me to use this picture of her. She's just qualified or graduated as a music therapist in this photograph. And I think the thing that strikes you about this is she looks fine. She looks absolutely normal. And this is part of the problem, really. If Tess had to run because a dinosaur was chasing her down the road, she'd be really breathless. She might feel faint and she might actually collapse because of that extra strain that's put on the heart when she has to exercise. And it's also one of the reasons why there's a delay in diagnosis, because the symptoms of this condition, such as breathlessness, fatigue and chest pain, are actually very common symptoms, and they're more commonly associated with more common conditions such as asthma or just being unfit. And so these patients go through various doctors and their diagnosis is delayed because it's a rare condition. It's also a progressive disease, and we know that, as I've said already, that the end result of this narrowing of the blood vessels is a strain on the right side of the heart and eventually what we call right heart failure, because it's failing to do what it's meant to do. Patients have breathlessness, chest pain, poor exercise tolerance, swelling of their legs, and they have a poor quality of life. And as the disease progresses, they have more and more admissions to hospital with right heart failure. And the bottom line is very telling. So if you have idiopathic pulmonary arterial hypertension and you receive no treatment, the median survival is only about 3 years. And that's very comparable to sort of cancers. So this is a very serious condition. I'm sorry, this looks like a bit of a complex slide from the start. This is the blood vessel. These are the layers, and we're focusing on the endothelial layer, the thin layer that's lining the lumen or the hole in the blood vessel. And what we know in patients with pulmonary arterial hypertension is that there are 3 pathways that are abnormal. There's too much endothelin-1, which is a little molecule that causes blood vessels to constrict and causes the cells to proliferate, multiply. There's not enough nitric oxide and prostacyclin, and both of these cause blood vessels to open up and are anti-proliferative. So there's too much endothelin, not enough nitric oxide and prostacyclin. And these observations have been the basis of the treatments that we give these patients. So we give them endothelin receptor antagonists. They block the action of endothelin. Phosphodiesterase inhibitors. They enhance the action of nitric oxide. One of the most common drugs we give patients is Viagra, which always cause a little bit of sort of humour or consternation. Or we replace the prostanoids, prostacyclin pathway with prostanoids, and they're very short-acting drugs. At the moment, we have to give them either as a continuous infusion with a pump or a regular nebulized form of the drug. We're lucky that there is another drug right at the bottom here, Selexipag, which works on the prostacyclin receptor, which will be available. It is available in the world, Europe, but in this country, the commissioners haven't agreed that we can use it. Hopefully, we will be able to use it soon, because that's a tablet. There are national, international guidelines which we follow in the treatment to investigate and manage these patients. But NHS England and this nice lady here tell us exactly what we can do. So with these drugs that I've been talking about, how have we been doing? So this is a survival curve here, so 100% survival, 0% survival days, so this is about 3 years. And these two lines here, well, one of these is the idiopathic pulmonary arterial hypertension, for instance. So we can see that still, with treatment, the survival is only about 65% at 3 years. Now that does represent an improvement compared to the pre-treatment era, 10-15%, but not a lot really. So there's a lot of more work to be done. So what things have changed recently that have helped us advance the treatment of these patients with the drugs that we have available? So this does sound obvious, but until relatively recently, we weren't allowed to treat patients with drugs until they got quite bad. Then this study, the early study, looked at patients that were mildly symptomatic. And this is a study that used a drug called bosentan, so that's one of the endothelin receptor antagonists, and compared to placebo. And on the vertical axis here is pulmonary vascular resistance, so that's essentially how narrow the blood vessels are in the lung. And we can see the patients that receive placebo, or no drug, over 6 months, their resistance increased. So shows again, it's a progressive condition, even in those mildly symptomatic patients, but if they receive bosentan, it decreased. And because of that, the commissioning guidelines now allow us to use drugs earlier on in the condition. Treating patients with multiple drugs is better. Again, sounds like common sense, but only until fairly recently have we got the evidence now that treating patients with 3 drugs is better than 2, and 2 drugs is better than 1. This is an example from a recent study using selexipag. That's that new drug that we are not allowed to use yet, but hopefully we will soon, acting on the prostacyclin pathway. Again, time on the bottom, and this is patients without an event. Now, an event was defined as either death or admission to hospital with right heart failure, or the need to step up their treatment with the intravenous prostacyclin, for instance, or just a deterioration in their condition. And we can see that compared to placebo, there was an improvement with selexipag. And the important thing is those patients were mainly on combination therapy already. So it's basically saying, and there were some subsequent studies to also show this, that 3 drugs are better than 2. Now, when we do that catheter test and measure the blood pressure in the lungs, we also do what's called a vasoreactivity test if we think the patient has idiopathic disease. And this is really important. We give them nitric oxide gas. And if their blood pressure in the lungs drops by a certain amount, a lot, then they're called responders. And that's only a minority of patients. But it's really important because those patients can be treated with very cheap drugs, calcium channel blockers like amlodipine, nifedipine, diltiazem, and they do incredibly well. So if you don't do this, it's a crime. And if you treat them with the more expensive drugs, it's a crime because they probably won't do as well anyway. Most patients, however, are non-responders. And then what we're doing now and this is a sort of a more recent progress, is risk assessing the patients. So these are the non-responders, and now we risk assess them according to this table, which will come down in a minute, to low and intermediate risk or high risk. And if they're low or intermediate, for instance, if they're really low, then we just start with 1 drug. If they're intermediate, 2 drugs. If they're high risk, we start with 2 drugs, and one of them is this intravenous prostacyclin, because that's the strongest and has the most evidence behind it. This is the table, called traffic light table. Green is good, essentially. For instance, no signs of heart failure, no progression of symptoms, no syncope, that sort of feeling faint or collapsing. A good walk test, for instance. And we're always trying to drive the patient to the left, to the green column. Some recent studies have shown that this is really important. So unfortunately, the colours that they used on their graphs don't correspond to the colours that I've just shown you, but bear with me. So this is survival on the vertical axis and years on the horizontal axis. So if they're in the low risk, which is blue, they do very well. This is right at the beginning. If they're green or intermediate, they don't do so well. And if they're high risk, they do very badly. And if you now look at them 4 months later, those ones that were bad to start with but have improved to low risk, the blue, are just as good as the ones that stayed in the low risk. So it just shows you how important it is to push patients to the low risk, and also those patients that were low risk and went to high risk do very badly, just as bad as the ones that stayed in the high risk. So this information is really important and will support a much more aggressive approach to treating patients. Finally, I just have a few slides on personalised medicine, because that's where everyone wants to get. And to an extent, we have started to do this, but it's quite crude. So, for instance, the reversibility studies is a way of personalising treatment to patients, and also risk stratification is a way of personalising, but it's quite crude. And if we take something that on the face of it looks quite pure, like idiopathic pulmonary arterial hypertension, it's actually very heterogeneous, meaning that there's probably multiple mechanisms still that we don't quite understand. I've just picked out a few there, a few things that are different within the patient. Cytokine levels. So cytokines are proteins that are involved in inflammation, and they may be involved in all that thickening of the blood vessels, and also genetic defects. So this is a graph of cytokine IL-6, which we know is important for making blood vessels thicker in the laboratory, in animal experiments. And we can see these are patients without PAH, and this is patients with IPH. And we can see there's a big range. On average, IL-6 levels are higher than in the control population. However, it's really driven by this group here. And if we do a study looking at blocking IL-6 but use the whole population, the study may be negative. In fact, we have done a study recently and nationally, and we're waiting to hear the results, and it didn't stratify patients by their IL-6 level. But you probably want to do that, wouldn't you? And it's the same for lots of proteins and molecules that you can measure. This is a very complicated, and it's also squashed, so it looks rather odd. But essentially, that gene I was telling you about, the bone morphogenetic protein receptor 2, it's involved in cell growth, cell turnover. And if we can understand the genetic defects a little bit more, we can perhaps target therapies to the patients with known defects. For instance, we know that if there are certain genetic defects in this BMPR2, the proteins don't fold properly, and therefore they don't work properly. And there are drugs that can help with that. Also, the receptor protein might be degraded too quickly. Chloroquine is a very cheap drug, but that can prevent that. And then finally, in terms of the ones I've just picked out, the actual protein that acts on the receptor, the ligand, BMP9, we know that the gene for that is defective in some patients. So in those patients, perhaps they will benefit by giving the patients BMP9, and that's being looked at present. So understanding what we call the deep phenotype of the patient will allow a more personalised approach. And this is my last slide. I think it's my last slide. What would be really good is if we can actually get cells from patients that are relevant to the blood vessels without actually waiting for them to have a transplant or unfortunately die. And you can actually grow endothelial cells from blood samples. They're called blood outgrowth endothelial cells. And I don't know if you can see that, but you start off with an extract of blood, and then after a few weeks with the right medium and a lot of care, you can get endothelial cells growing. This was meant to show some staining, but it didn't come out to prove they were endothelial cells. Now, we don't know exactly where those cells come from. We don't know they come from the lung. But what's important is if they behave as if they're different to blood from patients who haven't got pulmonary arterial hypertension. So this graph down here, these two columns here are from healthy patients, and these are from patients with pulmonary arterial hypertension. The cells are treated with a cytokine called interferon, and this is a protein that's produced by interferon. And we can see there's a slight increase in control cells, but there's a big increase in the cells from PAH patients. And that we know that does happen. You know that's important. If we take the cells from patients, for instance, who've had a transplant, we take the cells. So they are representative. We're not quite sure where they come from, but they are representative. And there's some work going on here. This was from Jane Mitchell's group. I don't know if she's here, but anyway, this is from her group. And so these cells may provide a platform to look for individual responses to drugs and therefore personalise medicine. So in summary, pH represents a collection of rare but serious conditions associated with narrowing of these pulmonary arterial vessels. The current treatment uses pulmonary vasodilators. It doesn't actually address the thickening of the blood vessels. Maybe Martin will talk more about that. There has been some improvement, but there's still a lot to do. I think recent advances include treating earlier, treating with more drugs, and by stratifying their response according to their response to drugs, and also overall risk. But I think the future treatment of patients with PH will hopefully include this more personalised approach, for instance, based on the level of proteins, molecules we measure in the blood, and also looking at their gene defects. Thank you.